colon and rectum. Question and answer session. Welcome to today's podcast, where we discuss the main aspects of surgical management of benign pathologies of the colon and rectum. Our conversation is structured in a question and answer format to support medical students, surgical residents, clinicians, and all listeners interested in the surgical management of benign pathologies of the colon and rectum. Pause the podcast after each question to attempt answer. Let's begin. Diverticular disease background question. What is diverticular disease? Answer. Diverticular disease encompasses a range of manifestations associated with diverticulosis of the colon. Question. What are the types of diverticula? Answer. There are true diverticula, which are rare and congenital, and false diverticula, which are common and consist only of the mucosa and muscularis mucosa. Question. How prevalent is diverticulitis and what factors contribute to its occurrence? Answer. Diverticulitis is primarily a disease of modern times, linked to dietary changes and the aging population. Pathophysiology and epidemiology. Question. How do diverticula form in the colon? Answer. Diverticula form when hypertrophy of the colon wall muscles, a narrowed lumen, and disordered motility create high-pressure zones, causing the mucosa to herniate through weak spots in the wall. Question. Where do diverticula most commonly form in the colon? Answer. Diverticula usually develop on the mesenteric side of the colon, where the vasa recta penetrate the muscular layer. Question. Why are vasa recta considered weak points in the bowel wall? Answer. The vasa recta, which are small blood vessels supplying the colon, are considered weak points due to their penetration of the bowel wall, making it susceptible to herniation and diverticulum formation. Question. What causes diverticulitis in the colon? Answer. Diverticulitis may result from increased pressure, inflammation, impaired blood supply, or trauma at the weak points in the diverticulum, which can lead to perforation and infection. Question. What role does the mesentery play in diverticulitis? Answer. The mesentery often contains the infection or inflammation to a localized area, thereby preventing it from spreading to the peritoneal cavity. Question. What are the potential complications if diverticulitis is left untreated? Answer. If not treated, the infection can extend beyond the mesentery, resulting in peritonitis and sepsis. Question. Which areas of the colon are most commonly affected by diverticular disease? Answer. The sigmoid and descending colon are typically affected, while the rectum is generally not involved. Question. How does the prevalence of diverticulosis change with age? Answer. The prevalence of diverticulosis increases with age, affecting about 40% of individuals aged 50 to 60 and over 60% of those older than 80. Question. What is believed to be the cause of diverticulitis development? Answer. Diverticulitis is thought to develop when a diverticulum becomes obstructed, leading to bacterial overgrowth, inflammation, and increased pressure. Question. How does diet affect the risk of developing diverticular disease? Answer. Diets typical of Western countries that are high in red meat, fat, and refined grains increase risk, while diets rich in fiber, fruits, vegetables, and whole grains reduce risk. Question. What lifestyle factors influence the risk of diverticular disease? Answer. Central obesity and smoking increase the risk, while physical activity decreases the risk of diverticular disease. Question. How do vegetarian diets and fiber intake affect diverticular disease risk? Answer. Vegetarian diets and high fiber intake significantly reduce the risk of developing diverticular disease. Clinical evaluation. Question. What are the common symptoms of diverticulitis? Answer. Symptoms include abdominal pain, usually in the left lower quadrant, fever, changes in bowel habits, anorexia, and urinary urgency. Question. What findings may be observed during physical examination of diverticulitis patients? Answer. Localized tenderness, abdominal distension, and a palpable mass may be found if a phlegmon is present. Question. What does rectal bleeding indicate in patients suspected of diverticulitis? Answer. Rectal bleeding is rare in diverticulitis and suggests other diagnoses such as ischemic colitis or inflammatory bowel disease. Question. Which imaging modality is most useful for diagnosing diverticular disease? Answer. Computed tomography is the most useful tool for diagnosis, exclusion of other conditions, and severity classification. Question. What are the computed tomography signs of diverticulitis? Answer. Computed tomography signs include diverticula, colonic wall thickening, pericolic fat stranding, and abscess formation. Question. How is the severity of diverticulitis commonly classified? Answer. The modified Hinchey classification is commonly used to describe the severity of diverticulitis. Question. What are the grades of diverticulitis? Answer. Diverticulitis is graded from grade 0, mild, to grade 4, fecal peritonitis. Question. What findings are seen on computed tomography scans for grade 1 diverticulitis? Answer. Grade 1A shows phlegmon and pericolonic fat stranding, while grade 1B shows abscess formation. Question. What are the limitations of computed tomography scans in diverticulitis? Answer. Computed tomography has difficulty distinguishing between grade 3, which is purulent peritonitis, and grade 4, which is fecal peritonitis. Question. What is grade 0 diverticulitis? Answer. Grade 0 disease describes mild clinical diverticulitis and is commonly used despite not being part of the original publication. Question. What characterizes grade 1A diverticulitis? Answer. Grade 1A is characterized by phlegmon, colonic wall thickening, and pericolonic fat stranding. Question. What defines grade 1B diverticulitis? Answer. Grade 1B disease involves a pericolonic or mesocolic abscess in addition to grade 1A characteristics. Question. What is grade 2 diverticulitis? Answer. Grade 2 disease is defined by the presence of distant intra-abdominal or pelvic abscesses. Question. What is grade 3 diverticulitis? Answer. Grade 3 disease is defined as generalized purulent peritonitis. Question. What is grade 4 diverticulitis? Answer. Grade 4 disease is characterized by fecal peritonitis. Question. When should endoscopy be performed after an acute diverticulitis episode? Answer. Endoscopy should be performed 6 to 8 weeks after an acute episode to minimize the risk of complications. Question. What is the purpose of endoscopy in diverticular disease? Answer. Endoscopy confirms the presence of diverticular disease, assesses its extent and severity, and excludes other colorectal conditions such as colorectal cancer, inflammatory bowel disease, and ischemic colitis. Question. Why should endoscopy be used cautiously in the acute setting of diverticulitis? Answer. Endoscopy should be approached with caution during the acute setting due to the risk of worsening perforation. Question. Is routine colonoscopy necessary for all patients after diverticulitis? Answer. Routine colonoscopy is not necessary for all patients, especially those with uncomplicated cases diagnosed by computed tomography scan. Question. What is the risk of colorectal cancer in patients with diverticulitis? Answer. The risk of colorectal cancer in patients with diverticulitis is low and comparable to the risk in the general population. Question. How should the decision to perform endoscopy be made in diverticular disease patients? Answer. The decision should be individualized, considering diagnostic certainty, symptoms, colorectal cancer risk factors, and procedural risks. Management uncomplicated diverticulitis. Question. How is the treatment approach for uncomplicated diverticulitis determined? Answer. Treatment is individualized based on symptom severity, with most cases managed as outpatients. Question. What are the mainstays of treatment for uncomplicated diverticulitis? Answer. Pain medications, short-term dietary modifications such as clear liquids followed by a low-residue diet, and traditionally antibiotics are used. Question. What do recent studies suggest about antibiotic use in uncomplicated diverticulitis? Answer. Recent studies question the necessity of antibiotics, as they may not significantly impact recovery or complications. Question. What condition can mimic diverticulitis? Answer. A small percentage of cases diagnosed as diverticulitis are actually colonic neoplasms. Question. What is the prevalence of colonic neoplasms among patients diagnosed with diverticulitis? Answer. 1 to 3% of diagnosed cases are actually colonic neoplasms, with higher rates in complicated cases. Question. What evaluation is recommended after recovery from diverticulitis? Answer. Colonoscopy is recommended 4 to 8 weeks after recovery to rule out malignancy. Question. What is the recurrence rate after an initial episode of uncomplicated diverticulitis? Answer. 10 to 35% of individuals experience a second episode after the initial episode. Question. How does recurrence affect the likelihood of surgery in diverticulitis? Answer. More episodes of diverticulitis increase the likelihood of recurrence and severe complications, which can lead to surgical intervention. Question. Why was elective surgery previously considered for diverticular disease? Answer. Elective surgery was considered to prevent severe diverticulitis, especially after multiple episodes. Question: is the number of attacks of uncomplicated diverticulitis still a strong indication for surgery? Answer: the number of attacks is no longer considered a strong indication for surgery. Question: is young age a primary factor in deciding for elective surgery in diverticular disease? Answer: young age alone is no longer a primary factor in the decision for elective surgery. Question: when is surgery not reserved for diverticular disease? Answer: surgery is not reserved primarily for complicated diverticulitis or cases unresponsive to medical management. Question: what factors are important in personalizing care for diverticular disease? Answer: individual risk factors, disease characteristics, lifestyle, and patient preferences are crucial in management decisions. Question: what was the outcome of the direct trial for elective sigmoidectomy? Answer: elective sigmoidectomy improved quality of life in patients with recurring diverticulitis and ongoing complaints compared to conservative management. Question: what proportion of conservatively managed diverticulitis patients eventually require surgery? Answer: nearly half of conservatively managed patients eventually require surgery due to severe complaints. Question: what criteria are considered for individual assessment before surgical intervention? Answer: individual assessment takes into account attack frequency, ongoing symptoms, quality of life impact, age, medical condition, and surgical risk. Question: what is the objective of surgery in diverticular disease? Answer: the surgical objective is to remove the affected segment of the colon, typically the sigmoid colon, and connect the healthy ends. Question: what are the margins for surgical resection in diverticular disease? Answer: the proximal margin should be in healthy bowel, while the distal anastomosis is made to the upper rectum. Question: what are the surgical approaches for diverticular disease? Answer: approaches include open, laparoscopic, hand-assisted, or robotic surgery, with minimally invasive surgery offering faster recovery and less pain. Complicated diverticulitis. Question: what defines complicated diverticulitis? Answer: complicated diverticulitis is defined by the presence of an abscess, fistula, obstruction, or free perforation. Question: what is an abscess in the context of diverticular disease? Answer: an abscess is a localized collection of pus associated with diverticulitis. Question: how are diverticular abscesses treated? Answer: smaller abscesses can be treated with antibiotics, while larger abscesses require drainage. Question: are recurrence and complications common after recovery from diverticular abscess? Answer: recurring episodes and increased risks of recurrence and complications are common after recovery. Question: what do the American Society of Colon and Rectal Surgeons guidelines recommend after successful non-operative treatment of diverticular abscess? Answer: the guidelines recommend considering elective resection due to the balance between managing recurrence risk and avoiding unnecessary surgery. Question: what is a fistula in diverticular disease? Answer: a fistula is an abnormal connection to surrounding organs, often a complication of diverticulitis. Question: what are common types of fistulas associated with diverticulitis? Answer: common fistula types include colovesical, to the bladder, colovaginal, to the vagina, and colocutaneous, to the skin. Question: how are fistulas managed in diverticular disease? Answer: management typically involves antibiotics, imaging, and surgical resection of the involved colon and fistula tract. Question: what is obstruction in the context of diverticular disease? Answer: obstruction refers to impaired passage of bowel contents due to structural changes from diverticulitis. Question: how can diverticulitis lead to colonic obstruction? Answer: fibrosis of the colonic wall from diverticulitis can cause stricture formation, resulting in partial or complete obstruction. Question: how is partial obstruction due to diverticulitis managed? Answer: partial obstruction is managed with a nasogastric tube, antibiotics, fluids, bowel rest, and elective resection after malignancy is ruled out via colonoscopy. Question: how is complete obstruction managed in diverticular disease? Answer: complete obstruction unresponsive to therapy requires emergency surgery. Question: what is perforation in diverticular disease? Answer: perforation refers to a breach in the bowel wall due to diverticulitis, leading to diffuse peritonitis. Question: what are the clinical presentations of perforated diverticulitis? Answer: Clinical presentations include diffuse peritonitis, rebound tenderness, guarding, fever, tachycardia, and hemodynamic instability. Question: what findings may be seen on imaging in cases of perforated diverticulitis? Answer: imaging may show free abdominal fluid, signs of peritonitis, and free intra-abdominal air. Question: how is perforated diverticulitis managed? Answer: surgical intervention is the primary treatment, with resection and abdominal washout to control infection. Question: what is Hartman's procedure? Answer: Hartman's procedure involves colon removal and then colostomy, which is often not reversed due to morbidity and mortality risks. Question: are there alternatives to Hartman's procedure? Answer: several studies are exploring alternatives to Hartman's procedure due to its drawbacks. That's it. Thanks for tuning in. If you enjoy our content, please like, share and hit the subscribe button. It's the Everything Surgery Podcast. Dissect the extraordinary.